title's pretty dry, and usually when people talk about papers and science and proteins and little biochemical transporters, most people fall asleep. But the reason for talking about this is we have some fantastic data that we have from collaborative work on the effect of enzyme replacement therapy and survival in pancreatic cancer. And because of this, I'll present an overview. It's a fairly silly thing to write. Organ failure is bad for you. We all know it's bad for you. And when we see liver failure, we know that a person's duration of survival is related to the severity of liver disease. It's very clear. Same for heart disease and heart failure. The same for respiratory failure. Here is a score for COPD. Even if we want to call it brain failure, if we have dementia, mortality is very strongly related to the severity of disease. Renal disease. We all know that renal failure, even though we've got transplantation and even though we've got dialysis, we know that renal failure is associated with poor survival. So why do we not talk about pancreatic failure? Surely pancreatic failure has got to be dangerous. We cannot live with organ failure. That is why we have all the machines, all the interventions in hospital to keep people with organ failure going. So what about pancreatic exocrine insufficiency and diabetes? So if we go to the literature, insulin was discovered in 1921 and it became widely available in 1923. And the figures are just very simple. They just show mortality for people with diabetes. And once insulin was introduced, mortality obviously reduced hugely. And then later on, this paper is from the early 90s, in a very large, well-conducted study, when control of diabetes was what they call intensive. The HbA1c was lower, the blood sugars were lower throughout the day, and this led to far less end-stage organ disease. Here is a figure of the number of patients who had retinopathy on the bottom left-hand side. So when we treat pancreatic failure in terms of the endocrine function well, we improve outcomes. What about the exocrine function? So this paper in the Annals of Surgery in early 90s looked at 50 patients who had total pancreatectomy. It looked at medium and long-term outcomes. Patients were given 20,000 units of lipase with meals, and the typical surgical observation study, a very mixed bag of indications for surgery. And what it found is that with enzyme supplements, there's surprisingly normal profile of vitamins in the blood, normal vitamin A, E, D, normal trace elements. What they did see is that patients were not absorbing all the fat, and there was a mean of 16 grams of undigested fat within the stool. And this paper was really quite insightful in it. They looked at bone density, and although there was normal serum levels of vitamin D, there was reduced bone density in this cohort, and this is going back 30 odd years now. Now, what we know and what we think as being quite clever and novel in the pancreas community is we talk about sarcopenia and we talk about bone density in patients with chronic pancreatitis, and we've got the papers by Kevin Conlon and his team and so on, and they've been published in the past 5-10 years, but they're describing the same thing. So why have we made such little progress in terms about thinking about the harmful effects of pancreatic exocrine insufficiency, and where is all the literature? Well, part of the problem is seeing the woods for the trees. Pancreatic cancer is awful. It's absolutely awful. And when we think about trying to improve the care for patients with pancreatic cancer, we have a lot of things on our agenda. We have a very morbid operation, and I'm going to show you just how dangerous a Whipple's operation is. We also have centralization of services, which is only a recent thing. We've only had pancreas specialists recently. Hospitals in the UK have only been operating on more than 10 Whipples per year for the past 5-10 years. Prior to that, people were doing a Whipple once every 2 months. Chemotherapies have been a focus for trying to improve outcomes, and we've spent millions and millions of pounds. We've tried different surgical techniques, taking away lymph nodes, taking away portal veins. Pancreas exocrine insufficiency is small print. So this is mortality. This is actual 90-day mortality in England over the past 12 years. We have an elective planned operation. Someone, you know it's happening, and despite that, 1 in 10 patients died within 3 months of a Whipple only 12 years ago. Because of centralisation, because of improved intensive care, because of better ways of managing complications, mortality has reduced and it's now 4%, but that's still incredibly high. It's higher than it is for aneurysm surgery, and it's far higher than it is for colorectal surgery and so on. What about the disease? It's a busy slide for a reason. This is a Lancet paper that shows survival in England and Wales over the past 40 years for all common and not so common cancers. Pancreas is near the top in terms of the prevalence, the number of patients with cancer. And pancreas cancer is remarkable for 2 reasons. The 5-year survival and the 10-year survival for pancreatic cancer has not improved one bit over 40 years. Every other cancer, survival has improved to some degree. And on top of that, pancreas cancer has the lowest survival of any of these cancers. It's an awful disease. What has our millions and millions of pounds of investment in chemotherapy got us? Well, it has 1 month extra survival for patients with unresectable disease, and it gives us a few months extra survival in patients with resectable disease. But pancreatic cancer is now firmly on the agenda for politicians and for research funders. The all-party parliamentary group is a group formed from politicians from the different parties, and they want to see improved funding, improved outcomes for patients with pancreas cancer. And we're getting there. We've got specialist teams, we've got specialist surgeons who only do liver and pancreas surgery. Some guys do just pancreas surgery. We've got specialist dietitians, radiologists, oncologists and nurses. We've got whole teams who can focus now just on this problem. Chemotherapies are starting to become effective. We're also seeing funding from major funding bodies. We've just had a major funding grant from CR UK to look at immunology in pancreas cancer. So it means we can now focus on the small print, but we need to look under quite a few stones to see the evidence for whether PERT can improve survival. Harold Schrem is a surgeon in Hanover who I collaborate with, and Harold has the only paper in the literature that shows the effect of enzymes upon any form of surgery. And in patients undergoing surgery for chronic pancreatitis, which is a hobby of Germans, surgeons in the UK just try and avoid chronic pancreatitis like the plague. The Germans love them, they operate on them non-stop. So they have huge numbers. So 147 patients undergoing surgery for chronic pancreatitis. And Harold stratified patients by whether they received enzymes or not. And there was a significantly greater survival in patients who received enzymes compared to those that didn't. So problem with all surgeons is we're a little bit superficial. There's no quantification of enzymes, so there's no fecal elastase, there's no breath test, there's no quantification of the exocrine insufficiency, and it's an observational study, but it's the best we've got. So we nicked Harold's idea, and we looked at survival amongst consecutive patients undergoing Whipples in Birmingham. So we have 409 patients undergoing pancreatic Whipples for cancer. And we looked at PERT use. Again, we don't have fecal elastase testing as a routine, unfortunately. We don't see many differences between the patients who received enzymes or didn't receive enzymes. What we did see is that we're more likely to prescribe enzymes now. At the start of the study period, only 1 in 5 patients was receiving enzymes. Towards the end, we're nearly at half. There was also an association between enzyme replacement and wound infection, which is a bit odd. I won't talk about it now, but if you remind me and you want to talk about it at the end, I've got an idea why that might be. But when we look at survival, the usual things come out as being significantly associated with survival. The type of cancer, pancreatic adenocarcinoma, the tumour stage, the resection margin status, whether we have to do a vascular reconstruction, they were all significantly related to survival. But so was enzymes, or so were enzymes. And when we do a multivariate analysis to try and understand relationships between all these different variables, we see that the effect of enzymes is independent of the effect of the diagnosis or the tumour stage. It really seems that enzymes amongst patients who have a Whipple makes them survive longer, and this is the survival curve. And it's really remarkably striking. It's far different than the effect of chemotherapy. It's almost too good to be true, so we thought we'll have a look at the dose, and we see a dose effect. The patients with the highest dose of enzymes have the greatest survival benefit. The patients with the lowest dose and the patients where the dose couldn't be ascertained is in between the two. We also see biologic concordance. We don't have fecal elastase, but what we did was to use the pancreatic duct width as a surrogate for exocrine insufficiency. When the tumour obstructs the duct gets big, the gland becomes fibrotic, and it no longer produces enzymes. So in the patients who had a normal, non-dilated duct, we saw enzymes had no effect upon survival. But in the patients with a dilated duct and therefore presumed pancreatic exocrine insufficiency, we see the difference. So why do we see this? So there's a potential role for vitamin D. There's a potential role for vitamin E. We all know that these are fat-soluble vitamins. We need our enzymes to absorb our fat-soluble vitamins. There are many papers looking at a role for vitamin D for many different cancers, and you can find it in pancreatic cancer, and I'll come to a couple of them. I haven't got time to go over all of them, but there's evidence there. So is it vitamin D? So there's a very large population-based study from the US. So over 100,000 people were followed up for 20 years, and their vitamin D levels were estimated based upon their ethnicity, whether they lived somewhere sunny or whether they lived somewhere like Birmingham, how much dietary vitamin D they had, their body mass index, and their exercise activity. And this was based on a validated score that actually correlated these variables to known serum levels of vitamin D. And they have over 2 million years of person follow-up. And they identified nearly 600 pancreatic cancers. Patients with people with the highest levels of vitamin D had a risk for pancreatic cancer of 0.65, so almost a 100%, or half that of those patients with the lowest levels of vitamin D. And then this study measured vitamin D levels amongst patients with pancreatic cancer. And they found that patients with advanced disease, locally advanced disease, or metastatic cancer, those patients with the lowest levels of vitamin D had a shorter survival. This is really the landmark paper for a role for vitamin D in pancreatic cancer, and it was published in Cell in 2014. Cell is an incredibly high impact journal, and articles only get in there if they're very rigorous and come from incredibly well-respected units. So pancreatic cancer is, if we take a pancreatic cancer lump, it's only really 10% cancer. The other 90% is pancreatic stroma. Pancreatic stroma is just hard fibrous tissue, but it's more than that. It has a controlling relationship with the cancer. And the reason why pancreatic cancer is so resistant to chemotherapy is not because of the behavior of the cancer cells, it's because of the behavior of the stroma. So the stroma with pancreatic cancer is essential. And here you see some tumor cells with stroma all the way around. Why am I talking about it? Pancreatic stellate cells are the controlling cells of the stroma. These cells can be quiet or benign, or they can transform. And in cancers, they're transformed and active. We also see activation in chronic pancreatitis, and this is why chronic pancreatitis is associated with a 20-fold increase of cancer. When these cells are activated, they produce insulin growth factor 1, connective tissue-derived growth factor, and other cytokines, which induces pancreatic cancer. Pancreatic cancer cells then positively feed back to the stellate cells, and so on. Why am I talking about it? I'm talking about it because the vitamin D receptor is the key controller of the pancreatic stellate cell. So Vitamin D receptor is expressed in high levels in pancreatic stellate cells, not in pancreas. And in cancer, there's much more vitamin D receptor stellate cells than in non-cancer stellate cells. When these stellate cells are shown vitamin D, it changes their behavior. They become benign again. When they're exposed to calcitriol, which is a vitamin D analog, they store lipids inside the cells, which you can see here in green. And this is a phenotype of the benign state of these stellate cells. When human cancer pancreatic stellate cells were shown vitamin D, it changed the expression of a protein that is very strongly related to cancer activity, SMA, smooth muscle actin. It also changes, showing vitamin D to the pancreatic stellate cells, changes the gene profile of over 2,200 genes in these cells. The effect on almost all of these genes is to reduce the expression of proteins. It reduces angiogenesis proteins. If you grow pancreas cancer cells on their own and give them vitamin D, there's no effect on angiogenesis. If you grow pancreas cancer cells along with the stellate cells, there's a huge increase in angiogenesis proteins. When you grow pancreas cancer cells with the stellate cells and vitamin D, then it really does stop angiogenesis. I said that pancreas cancer cells are quite sensitive to gemcitabine on their own. So when pancreas cancer cells are shown gemcitabine, the cells die quite rapidly. When you add vitamin D, it makes no difference. When you show pancreas cancer cells gemcitabine, when they're also grown alongside the stellate cells, nowhere near as many cells die. The stellate cells prevent the gemcitabine from being effective. But when you add vitamin D, you partly remove that effect, and gemcitabine is more effective. Tumours are smaller. This is vitamin D alone, this is gemcitabine, and this is gemcitabine with vitamin D. They have more gemcitabine in the cells when they're grown with vitamin D. And it's because, if we go back to talking about the stroma, what happens is the normal state of pancreas cancer is there's so much stroma there, it squeezes the blood vessels shut. So pancreas cancer is hypoxic. It doesn't have blood flow going through it. The gemcitabine can't get to the pancreatic cancer cells. When vitamin D is exposed to the pancreas cancer and the stroma regresses and the blood vessels open up and gemcitabine gets to the tumour, and then gemcitabine can be effective. And there's a difference in survival here in these animals who are given gemcitabine or if they're given gemcitabine and vitamin D. So that is a remarkable paper, and it demonstrates without doubt that the vitamin D receptor is very, very important in pancreatic cancer. It tells us that vitamin D, it tells us that something that we eat and that we metabolize is essential and plays a very important role in pancreatic cancer. But are we just overthinking it? Is it simply just better nutrition? Do enzymes just simply improve survival because of more calories and more protein and lipid absorption? We like to have randomized trials because we all think that somebody's being very clever when they do it, and they usually cost millions of pounds, so it must be good value for money. But observational studies can be incredibly powerful. The reason we know that smoking is very dangerous for us is because of a paper published in the BMJ by Doll, and it was a longitudinal study of doctors in the UK. And they followed up doctors throughout their careers and lives, and they looked at mortality related to smoking, and they saw that lung cancer, other cancers, heart disease was all more prevalent in the smokers, and there was also a dose effect. The people who smoked the most, had the most PAC years, had the worst outcomes. Observational studies are or can be very powerful. So if we take a step back, well, what model do we know where we see pancreatic exocrine insufficiency? Well, it's cystic fibrosis. This is a fantastic paper. In the 70s, pancreatic enzymes were not widely available. They were coming through. There were two big cystic fibrosis units that contributed to this paper, Boston and Toronto. They had similar numbers of people on their databases with similar ages, and no difference in respiratory function, bearing in mind the most common mechanism of death in patients with cystic fibrosis is lung disease. But people in Boston were shorter and lighter, and so they looked at this in more detail. The main difference in how the two groups were managed was with regard to diet. The Boston people had a low-fat diet to avoid steatorrhea. They did not receive enzymes, and they were told to have high calories. But Toronto advocated 20 to 30 capsules per meal of enzyme. I don't know what the enzyme was back then. And a high-fat diet, because they weren't worried about steatorrhea anymore, and a high-calorie diet. The respiratory care, the physiotherapy and antibiotics were similar, and there's a remarkable difference in survival between these two cohorts. The median age at death in Boston at the time was 21, which is similar to the rest of the population of USA and the rest of the population in Canada of cystic fibrosis patients. But in Toronto, the median age at death was 30, and the conclusion of the paper was that the difference in the survival was mediated by the effects of correcting enzyme insufficiency. So what do we have in pancreas cancer in terms of clinical trials? Well, we really don't have much. We know that patients with unresectable pancreatic cancer, when they were randomized to receive nutritional supplements with or without this type of fatty acid, we know that the study failed. The fatty acids made no difference on outcome, but we know that increased weight loss in this study was associated with a shorter survival and a worse quality of life. And we're really scraping the barrel here. 23 patients, so it's really not high quality evidence. We've got one randomized trial of 23 patients with unresectable pancreatic cancer randomized to enzymes or not. Those patients with enzymes actually gained weight, they had a higher fat absorption, and they had increased energy intake. The numbers are far too small to see any difference in survival. And that's it. So, in summary, optimizing nutrition through enzyme replacement therapy may lead to survival benefits in patients with pancreatic cancer, and this would be remarkable. We've spent millions and millions of pounds chasing chemotherapies. We've tried very, very major operations, and we make no difference at all. The answer might be partly right under our noses. We know it prevents weight loss amongst patients with unresectable disease, and there's a clear potential role for why vitamin D and why pancreatic exocrine insufficiency might be related mechanisms. But clearly further research is needed to really understand effects on survival and deeper effects on patient quality of life and other nutritional aspects. Thanks for your time.